Yes, well, I'm Philippe. I'm an occupational health physician, and I'm working at an occupational health service of COPSOQ, but I'm also attached to the Department of Public Health and Primary Care in the Ghent University. The majority of the work was done together with my colleague Mark de Meester, but who unfortunately died a few weeks ago, so he is not present, of course, to witness this presentation. Anyhow, I'm going to present the results of some analysis to determine cutoff points on organizational level for some psychosocial work environment factors. First, perhaps some thoughts about cutoff points and benchmarks. Cutoff points are well used in medicine and also psychology, and guides us in our decisions to declare somebody ill or not ill. Cutoff points are determined on the basis of a relevant outcome, health outcome, and enables us to make a distinction between good or bad for health or well-being. And so actually they are health-based reference values. The disadvantage is they are on individual level. We decide on those cutoff points if a certain individual is sick or not sick. Now, for psychosocial risk assessment, we use group level results. Group level results, commonly we compare them to reference values. Reference values from other peer groups, similar jobs, similar industrial sectors. We compare them if we are better or worse than that peer group we are referring to. The advantage of those benchmarks or peer group based reference values that they are group level, but the big disadvantage is you have no clue if that peer group is good or bad, if we are talking about a sick situation or a healthy situation. If the whole peer group is sick, then you are good. So that is a bit different when we are talking about health and well-being on group level. You have individual level cutoff points, we have that say something about sickness or non-sickness, we have benchmarks or other reference values, peer group values on group level, but we have no indication on healthy or non-healthy. Before I continue, I would like to have some words on need for recovery. Need for recovery, certain stress factors, whether they are work-related or not work-related, can result in short-term effects. Short-term health effects, which express themselves as fatigue at the end of a working day. On itself, that is no problem. Everybody is fatigued, is tired when he has finished his working day. The problem occurs when in between two working periods there is insufficient time to recover from that fatigue, and this will accumulate and eventually lead to long-term effects, expressed as mental health complaints, psychosocial complaints, burnout, and eventually lead to sickness absence. There are two criteria for developing those long-term effects. First of all, that fatigue has to have a certain degree, a certain level, high level. It must be high. You have to have a high need for recovery, and it must pertain for a prolonged time. We cannot, or we have no view on the time, but we have a view on the level of fatigue at the work at the end of a working day. That is called need for recovery, which can be measured by the need for recovery scale. It has been shown that this need for recovery scale is a predictor of mental disorders, psychosomatic complaints, burnout, and long-term sickness absence. It has been shown to be a reliable instrument and can be considered as an early and very sensitive indicator of reduced well-being at a certain point. If sustained, this will lead to illness. That point, at a certain point, you are not ill. So if we assess the need for recovery, we detect health effects in a very early stage before people get sick. Within the context of prevention, this is a very relevant parameter. It gives you a scale from 0 to 11. The higher, the worse. And the high need for recovery is when you have a score of more than 5 on 11. Again, this is on individual level. If you, when an individual has a level of more than 5 on 11, he has a high need for recovery. When it comes to organizational level, a very frequent parameter that is used is a percentage or another parameter for measuring sickness absence within an organization. However, sickness absence, or percentage, or another parameter regarding sickness absence, actually is a parameter of sickness within the organization. When we are talking about sickness, that is actually too late for prevention. Occupational health is a preventive discipline. When we talk about sickness, we are too late, we have failed. There has already been an impact on the health of the employee. Therefore, we thought perhaps when we use the percentage of high need for recovery within an organization, not sickness absence, but the percentage of high need for recovery within an organization, that could be considered as a parameter for mental unwell-being within that organization. And we are not too late to advise for measures to prevent sickness absence. We are working with a parameter that does not indicate illness, but does indicate early sign of illness. So the aim of this study was to determine cutoff points on organizational level based on the prevalence of high need for recovery within the organization. And of course, we did that since we are talking about a mental, psychological endpoint, we are talking about psychosocial work environment. We used data from our well-being indicator screening. That's an online questionnaire we use in SIGREX, and that questionnaire assesses a whole bunch of items related to prevention and well-being. The primary aim, of course, is to map bottlenecks on the well-being at work to advise the employer on which areas or which employee groups are at risk for certain things or where preventive actions need to be taken. That's absolutely the primary aim. But since we are collecting data on a standardized way, we can use secondary pooled data for scientific research. And that is what we did here. Our study population, okay, well, based on data, on baseline data, collected in 191 organizations, which we selected with at least 60% of response rate, to be sure that the organization was, the figures for that organization are representative for that particular organization. And the average was 180 employees per organization, with some rather small organizations and rather big organizations. And the mean response rate was 80%. But we are talking about, and totally we covered about 26,000 employees. But I'm not talking about those 26,000 employees. I'm talking only about the 191 organizations. These are our patients. And within those 191 patients, the mean high need for recovery percentage was 35%, with a very large range, 8.3 up to 77.4%. meaning in that particular organization with 77%, meaning that more than 75%, more than 3/4 of the employees there are working on the tips of the toes and are at increased risk to develop burnout if the situation continues. Now, for ROC analysis, we have to decide what is sick, what is not sick. First, we thought, and we did that, we took two quartiles of whatever. We thought, what is healthy for an organization, or what is unhealthy?
Excuse me. Sorry yes? For interrupting you, but your presentation has disappeared.
Oh.
I think you disconnected briefly.
You're disconnected, and then after you came back, the presentation disappeared. So you have to share screen again for some reason.
Yeah.
And that was this. That is very fine. We are back. You are back.
Oh, did you miss something? Do you have to recall something about this one, or not? Or do I have to repeat something?
No, it was very brief.
Yeah, we got that information from that slide.
Okay, so. So we decided, we thought that when 40% of your employees are working with a high need for recovery, that is really high. When you have more than 40%, you're, as an organization, you're not really a good pupil. And more than 40% of your employees are working on the tip of the toes. And have an increased risk for having for developing burnout. That's not a good thing. So first division between sick and non-sick. Sick was for us more than 40% high need for recovery in the organization. Bad guys. Then we thought, why not make a cutoff point for really good guys? We thought when you have less than a quarter of your employees with high need for recovery, you are really good guy. Then you have a sound, good organization and healthy organization. So we used two cutoff points: 40% for the bad guys and less than 25% for the good guys. These are the psychosocial work environments factors that we assessed. There were 18. 15 of them were COPSOQ, and we developed 3 non-COPSOQ factors. We used the short version of COPSOQ 2. We started at 2015, so there was COPSOQ 3 didn't exist then. And it's not only psychosocial work environment factors, 3 outcome parameters, actually exhaustion, subjective health and job satisfaction, more outcome parameters, but also included in COPSOQ. All factors, all 18 factors, were transformed to a score from 0 to 100. That is more a practical issue. It's more easier to talk about score from 0 to 100 to the employers. And we used the mean value per organization. So we have 191 points for each dimension. So we are not talking about 26,000 employees. We're talking about 191 patient organizations. To determine the cutoff points, we used ROC analysis, which gives us an optimum point where the maximum sensitivity and specificity is reached. And also you could determine the area under the curve, which gives you an impression of the value of the parameter. Area under the curve, the bigger the area of the curve, the more the blue line goes to the left upper corner, the greater the value of that value of the analysis. Then when the area reaches 1, it is perfect. When the area is only 0.5, it coincides with the green line saying it's worthless. In medicine and in psychology, nothing is 100%, so the perfectness will never be reached. And it is also always multifactorial. A more realistic approach of the accuracy is that we use 0.70. However, it is said 0.70 is said when we are talking about individuals. Now we are talking about organization, a conglomerate of many individuals. And we used two sets of ROC analysis, one to calculate cutoff points to be in the very good group, and a cutoff point to be to belong to the very bad group. I won't go to detail for the 18. I show you here the exhaustion, which is a very strong relationship. It has a very strong relationship with need for recovery. Of course, exhaustion is a consequence of being fatigued. The mean score for 190 patients is 36.4, with quite a broad range. For belonging, the cutoff point for belonging to the 25 to the very good guys is 33.9. For belonging to the bad guys is 36, with a very good area under the curve. The asterisks show the degree of difference of significance between the blue line and the green line. I show you here the ROC curve of the figure for 40% analysis, and you see this point here. One of the 190 corresponds with the cutoff point of 36.2. This point has been identified as a point with the highest sum of sensitivity and specificity. These are the corresponding cutoff points. To make it more practically, we rounded the cutoff points, saying when you have a cutoff point less than 34, you're a very good guy. If you have a cutoff point from 36 on, you're a very bad guy. In between is just yellow. We did it also for quantitative demands. Same system, mean, range, area under the curve to belong for the value of less for the good ones, area on the curve for the value for the bad ones. 38.9 becomes 39, 44.6 becomes 45. In between, yellow. Same thing again for emotional work demands. Mean 36, range, very large range. Cutoff point for the good ones, 30.6. For the bad ones, 34.6. Rather good area under the curve. Good significance. 30.6 becomes 30. 34.6 becomes 35. I'm not going to detail for for the 18, of course. This table, this slide shows you results for the factors that are positively associated with need for recovery, meaning when this factor increases, need for recovery will increase. So these factors need to be as low as possible. When you go, so the green, when you belong to the good guys, the cutoff point must be lower than that, your value must be lower than that. When you belong to the red guys, the value must also low. When you have a value bigger than that, you belong to the red guys. In this column, I gave you the mean values for the 191 organizations, and I colored this appropriately according to the cutoff points we assessed. And this here is a percentage of organizations that are in the red zone. I didn't show you here the areas under the curve, but I show you here the asterisks indicating the significance of difference between the green line and the blue line. This table shows you factors that are negatively associated with need for recovery. So when increasing this factor, the need for recovery will decrease. These factors need to be as high as possible. Hence, another direction of this sign. Again, I won't go through everything here. The blanks here means that there was no really big difference between the value for the green group and the value for the red group. Again, the mean figures, and again, the percentage of red organizations in the red zone. You can notice also here that there are 3 factors for the green values that are not significant. We'll keep that in mind. And these are the final slide, the final ones. Again, negatively associated, meaning these factors need to be as high as possible. Cutoff points for the red ones, cutoff points for the green ones, and the yellow ones. And here you see, when you look at the mean values, the 191, a first green field occurs. That's for job satisfaction. It's only even borderline 68, 68. Now, I went through it very quickly, but I can say that when we look at the mean values, benchmarks, if you would like to call them, 12 of them are in the yellow zone, which means that's okay. So it's okay. Actually, use of benchmark it's okay if we relate them to the cutoff points we established. But 5 of the dimensions were actually red when you would use the benchmark, and only 1 popped in to the green group, the very good group. And there was also quite a variety of organizations that were percentages of organizations that were in the red zone, depending on the variable. We also looked at the kind of evaluation of the ROC analysis. We have here the green group, we have here cutoffs for the red group, the range of areas under the curve. This was quite low for the green group. The value in brackets as the value for burnout, which was really an outlier. Most of the values were in between this range and this range. And the mean area under the curve without the value, without the outlier, was 0.67, 0.68. And if we take into account the 0.70 for the individual reliability, it is not so bad. However, for the lower cutoff points, 4 of them were not significant and reached not as high significance level as for the red group. The red group, every parameter, every cutoff point was significant, and most of them, the majority, very significant. So in conclusion, now we are talking now, it's not really a diagnosis bed sick or not sick, you should see it more of, we see it more as guideline values. On organizational level, we have now something on organizational level that is health-based, not peer group-based. And for the work results for the red zone, they seem to be quite reliable. And we could say that do not cross this line for that parameter. The work results for the green zone to be very, very, very good pupil. They are less reliable. Let's say, nice to have. When you're on the green zone, well, very good. Applause. You're on the good side. When you're yellow, okay, blah, blah. When you're red, definitely not. And of course, as for every research, further research is necessary. And I think that was it. Thanks.
Thank you, Philippe, for this very interesting presentation. Very much, thank you. Are there questions? I think I have two questions myself.
Yep.
I will start putting them, and there will be also time for the other participants. Okay. I have one question, Philippe.
Yep.
As far as I can see, I think it seems that you have high fractions of employees in your workplaces which are at risk for developing burnout or depression.
Yeah.
But it could be, but on the other hand, it might be that you have chosen a very high cut point for being at risk for burnout or depression. Have you also tried to look at a lower cut point, for example, covering that 10% are at risk and not these high fractions you have worked with?
No, we just also did it at 35%, but it's really 35% was really in the middle of 24, 25, and 40%. So that's it could also be the consistency of our population. A lot of them were. It was also public sector, and the public sector were mostly care institutions.
Oh.
Care institutions where you have a high degree of emotional things, workload, and care institution in Belgium is a problem. There's lots of people drop out and by sickness or by pension, and there's very low inflow. So there's a shorter personnel shortage as well in that sector. But it's not all care. It's not all care in our population, but quite a bit.
Thank you. So the context of these specific companies explains these high fractions who have need for recovery. And now now Hendy Ginting has a question. So Hendy, can you ask?
Yes, thank you, Herman, for the opportunity. I'm Hendy Ginting from Indonesia. So I agree with you. We are from all over the world. And thank you, Philippe, for the presentation. But I'm just curious about the cutoff point and the ROC that you did. Do you have this sample of people who are quote unquote normals and people who are already diagnosed as depression or burnout or whatever? Then the combination between this score resulting the cutoff point, or you have another way to get the cutoff? Thank you.
No, we don't have any diagnosis in the data set. So that's the only thing we can rely on is what we use for in our screening tool. In our screening tool, we use always the need for recovery. But there is a very strong relationship between our need for recovery and the burnout questions of the COPSOQ. We use the short version, therefore the two questions, and there's when I plot them on organizational level, the percentage of high need for recovery in the x-axis, and the mean burnout score in the y-axis, I don't have to draw a line. You see the line immediately. There's a very strong relationship between those two parameters. But no, we have no diagnosis. We only know the diagnosis is high need for recovery. You have high need for recovery or not.
Okay. Thank you, Philippe. That's all, Herman. Thank you very much.
Thank you very much for your comment. Yücel, did you have a question?
Yes, a short question. Maybe. Thank you very much, Philippe, for your presentation. It was very nice and mind opener, actually. My question, it is not a really question, maybe suggestion also.
Excuse me, Yücel, maybe you should say where you are from.
Oh, I'm from Turkey. Hello, everyone. My question is about you used NFR for the outcome measure, and you said that is a good predictor for the depression or depressive symptoms. Maybe you can calculate the estimation of the depression in the feature that if you have sensitivity specificity analysis of NFR, I don't know if you have this information. Maybe you can also calculate the how many depression you are going to expect in the future. You understand my question?
Yes, I do.
This would be very interesting because combine two sensitivity. I don't know how good.
Yeah. Yes. Yeah, it's a very good suggestion. Only now we are in a phase in our institution that we will monitor all kinds of. We will monitor also the reason for sickness absence. And since when we can cross the data of the need for recovery and the reasons of sickness absence, and then we have really the reason for the pathology, because in our questionnaire now we don't ask for any pathologies or for any diagnosis. But when people are getting sick, then we will have some kind of standardized registration of pathologies, and then at that point we will be able to do first follow-up studies and also link those two together: need for recovery and any mental disorder, whatever. But at the moment we cannot do that. But in the future, these are our plans. It's a very good suggestion. Thanks.
Thank you for this question and answer. I have a comment and a question. My comment is that this presentation had some methods which not everyone knows or understands. So I think that you have a challenge how to communicate that to people who are working with this in workplaces. But so this challenge you will have in the time to come, and it would be interesting in a year or two to hear how you have developed the way you present your analysis to those working with the problems in the workplaces? That would interest me in some years to hear. But I also have a question. You had 181 organizations, and you found that some issues related to social capital didn't really explain differences between workplaces. So my question is, a workplace has different departments, yes?
Yeah.
And so it might be that if you look at this on a department level, that you would find other factors being of interest. But of course, it might be that you don't have these data on being for need of recovery on that department level. But it could be that the picture would be quite different.
Yeah. We have on organization, when we give a report to the employers on an organizational level, we have data on department level, and we compare the data on department level, both for social capital, for need for whatever, for every parameter that is. So it should be possible to identify departments in our data set. It is possible. We do it on organizational level, but not for this study. I didn't do that because we would have, I think, 1,000 departments or something like that to compare. So then it would be an immense work, I think. But it's possible. It should be possible.
I'm not a statistical expert, but what triggered me was that some of the dimensions of COPSOQ, which we think have to do with social capital, like social support and quality of leadership, didn't really explain on this great organizational level the differences. But as far as I understand, these dimensions should play a role on the department level. Therefore, I just asked you.
Yeah, but I think it's perhaps not the correct endpoint need for recovery to point out those differences. We have also, I did it also for intent to leave. I did it also for commitment. Then for social capital was a very, very important factor. So so intent to leave, sickness absence, I think so, but definitely commitment and some other things also, job quitting, job satisfaction, but also some other things that were not relevant within the health issue of need for recovery, but for HR parameters like intent to leave and some other things we also asked for. That was really, really, really relevant.
Excuse me for stopping here, but I have forgot to look at the clock. We are 2 minutes after we should have finished here, but we would be, of course, very interested to read about a publication where you write down the results you have just presented. So thank you very much, Philippe. And now we are going to the south. We are going to Libya. We are going to Tripoli. And now Marwa Ali Ahmed Dufani will present results from Libya on psychosocial risk, eating habits, and cardiovascular disease.